There are many Asian countries, foreign students here, and a couple of days you can communicate with English. So Korean English is Konglish, Japan English, Janglish, Singapore English, India English, yes, English. Today my topic is of TOF, pulmonary atresia with VSD, pulmonary atresia with intact ventricular septum, and Ebstein. TOF and pulmonary atresia VSD is almost the same, but pulmonary atresia intact septum is different, and Ebstein also totally different disease entity. At the same time, I should talk. Okay. In TOF, there is a wide morphological variation in the spectrum of pulmonary stenosis and the VSD. The lesion described by the Dr. Fallot was considered to be 4 major defects: infundibular pulmonary stenosis, VSD, and the dextral position of the aorta, and the hypertrophied right ventricle. The big difference between normal heart and TOF is the formation of a conal septum. The conal septum, which normally follows a posterior and rightward course, has a superior, anterior, and leftward position in TOF, thus crowding the right ventricular outflow tract. By remaining anterior and superior, the conal septum fails to occupy the space above the ventricular septal between the left anterior superior and the right posterior inferior limb of the septal band, resulting in the typical malalignment ventricular septal defect seen in TOF. As Dr. Sir mentioned before, Crista supraventricularis gives origin to 2 large muscular bands: septal band, which courses along the free wall of the right ventricle, and the parietal band, which is located along the free wall of the right ventricle. The septal band shows as a prominent muscle trabecula along the upper portion of a interventricular septum, and the septal band also gives rise to the medial papillary muscle, and it continues towards the moderator bands, make up the septomarginal moderator band. Together, septal and the moderator band makes septomarginal trabecula, along which the right bundle branch travels. The moderate band inserts in the base of the anterior papillary muscle. The band is a stout myocardial bundle positioned in the central of apical portion of right ventricle. In some large mammals, it is more prominent and has been located to resist overdistension of the right ventricle. Indeed, it was this suggested protective action as the name of the moderator band. In addition, moderator band reinforces the septal surface as it divides into 2 limbs at the base, at the apex, and support the anterior papillary muscle before crossing the free wall of the ventricle. This subcostal long axis view of the right ventricle demonstrates the anterior deviation of the aortic septum, causing the infundibular pulmonary stenosis associated with the TOF. There is also supravalvular pulmonary stenosis with the dilatation of the pulmonary trunk. Aorta is overrides the interventricular septum. Gross anatomy of patient with tetralogy followed and the deficient conal septum. The arrow point to the conal septum, which is deficient. The aortic and the pulmonary valve are almost in direct contact. The pulmonary artery is very small. This is the photo of right ventricular outflow tract in the adult with the TOF. The anatomical basis of TOF is an anterior malalignment of the parietal band. As a result of this malalignment, a conal ventricular septal defect is created, and the right ventricular outflow tract is narrowed. Pulmonary valve may or may not also be stenotic or even atretic. A deeper cut into the right ventricle of the heart, shown in TOF, shows the common atrioventricular valve. The left component of the common atrioventricular valve is mostly posterior. Anterior portion is resected and demonstrating superior and inferior bridging leaflets as they cross the crest of interventricular septum. The aorta is override the interventricular septum, and the outlet septum is deviated anteriorly, causing the infundibular pulmonary stenosis, characteristic of TOF. Please note fibrous continuity between aortic valve and the superior bridging leaflets. The surgical anatomy as viewed through a right atriotomy, the division of obstructing muscle bundles along the anterior limb of the septal band. Division of these muscles is usually sufficient to relieve RVOT. View from the right atriotomy, the TRAS valve after patched closure of the ventricular septal defect, the end of the divided muscle bundles can be seen. This is a surgeon's view through transatrial incision when we're using the transpulmonary and transatrial total correction. And the transatrial right ventricular alpha tract muscle resection. The VSD is here. Extent of right ventricular incision in a classical transventricular approach, also showing the division of a corner branch of right coronary artery. And this is a mini transventricular annular incision in the transatrial and transpulmonary approach. For avoiding the damage of conduction bundle and the secure closing of VSD in the transition zone, one stitch is done on the ventricular septum, and the other stitch penetrates out TRAS valve annulus, and apart from the previous stitch, again penetrate in TRAS valve. So we can close this area securely. To improve exposure and access of to the posterior inferior quadrant of the ventricular septal defect, parietal extension of the infundibular septum is partially incised. Malalignment of VSD is closed. In this schema, the posterior inferior limb of the trabecular septum marginalis is well developed. The atrioventricular bundle is more deeply embedded within muscle, and also more closely related to the left ventricular aspect of the septal crest. Sutures are placed safely within this muscle, avoiding encircle of the crest of the ventricular septum. In this schema, the posterior inferior limb of the septal band is hypoplastic and is reduced to a fibrous rim formed by the confluence of aortic valve annulus and endocardial cushion tissue of the TRAS valve, establishing aortic tricuspid valve continuity. Because of hypoplasia of a posterior limb, inferior limb, the bundle of His is less deeply embedded and thus lies closer to the right ventricular surface of the septal crest. In this anatomic variant, the sutures are either anchored within the fibrous rim to avoid the bundle of the His, or approximately 5 millimeters from the ventricular crest. Dr. Kurosawa proposed the Conotruncal Repair because of the blood flow is more laminar and the outflow patch is shorter. But I don't recommend this type of surgery. When you incise or resect the hypertrophied muscles, please keep the endocardium sparing near ventricular septal defect to put the pledge sutures. Stitches are more secure on the endocardium than on the raw surface of the resected muscles. So personally, I recommend you would better put the transannular patching when you meet the very difficult infundibular stenosis. When you have more experience about TOF surgery, you can try to do small incision around there later. Next topic is a severe form of tetralogy followed, pulmonary atresia with VSD. Upper part of diagram is classified into 4 groups. In group 1 and 2, pulmonary arteries are well developed and the blood flow is supplied by the large PDA. The main pulmonary artery is absent in group 2. In group 3, the ductus is either absent or very small. Both left and right pulmonary arteries are diminutive, connecting to variable numbers of bronchopulmonary segments. The more important sources of pulmonary blood flow is epicars. Epicar means aortopulmonary collateral arteries. In the group 4, there are no mediastinal pulmonary arteries, and all bronchopulmonary segments are supplied entirely by epicars. In lower part of diagrams, epicars connected to either central pulmonary arteries within the mediastinum or lobar and segmental pulmonary arteries within the lung, and or do not connect with any pulmonary artery supplying lung independently. Depiction of histologic characteristics of aortopulmonary collateral artery before it enters the lung parenchyma. The epicar retains the characteristics of muscular arteries with a well-developed muscular media and adventitia. Within the normal lung, the medial muscle is gradually replaced by a thin, elastic lamina. In an unobstructed epicars, the changes of pulmonary vascular obstructive disease are mostly due to increased pressure and blood flow. In obstructed epicars, normal histologic anatomy is preserved with a thin elastic layer. However, we don't know the exact fate of epicars, whether it is obstructed or not obstructed. Gross anatomy of pterygium followed and the pulmonary atresia. The main pulmonary artery is a thin strand. Pulmonary atresia associated with the epicars. The descending thoracic aorta is viewed from the posterior perspective. The arrow points to the collateral artery to the right lung and the orifice of collateral artery supplying the left lung. Pulmonary atresia with intact ventricular septum is a totally different disease entity than pulmonary atresia with a VSD. Despite the implication from the terminology of a pulmonary atresia with intact ventricular septum is simply a defect of pulmonary valve. This diagnosis encompasses a spectrum of disorders that have important anatomy variations involving not only pulmonary valve, but also the thorax valve, the right ventricle, and the coronary circulation. These anatomy variations have important implications for the surgical approaches to be employed. This is a hypoplastic right ventricle outlining the distribution of the left anterior descending coronary artery and the right coronary artery. The main pulmonary artery is incised to display its origin of the right pulmonary artery and left pulmonary artery. Main pulmonary artery is open. The atretic pulmonary valve totally occluded connection from the right ventricle to the main pulmonary artery and dilated aorta. Right ventricle opened, there is a severe right ventricular hypertrophy. Arrow points to the atretic pulmonary valve, and also the conal septum and a septal band are seen. Atretic pulmonary valve is represented by the small dimple. Right ventricle has 3 portions: inlet, trabecular, and infundibular. Panel A is a tripartite alveoli, has 3 portions. Type 2, panel B is bipartite alveoli with absence of severely hypoplastic alveoli, and panel C posterior crest valve at the atrioventricular junction. Replacement. And the same patient, in the valvuloplasty, creating a monocuspid valve using the anterior tricuspid leaflet and part of posterior tricuspid leaflet with combined ventricularization of the atrial ventricle after orthotopic transposition of the septal and posterior leaflet. The arrow indicates a pleasure suture position to reinforce the running fixation suture. And this one is the creation of a bicuspid atrioventricular valve, anterior and posterior leaflet. And this one is a monocuspid valve using anterior leaflet. Torren Guasip proposed the band-like secondary structure of the biventricular myocardial body. This schematic drawing shows how one strand of myocardial muscle can form the entire heart. The forming of left and right ventricle is quite different. Here is the LT valve, that is the primary valve. It's a single strand, and once, second, third, it is left ventricle and right ventricle. So this is partially unrolled and hence partially elongated, mainly the right ventricular loop, to demonstrate the natural relative position of the segments. This concept will be applied when you repair the atrialized right ventricle or when you repair the dilated alveoli long-term after TOF correction. Thank you for your attention.